Good afternoon. Sorry for the delay. Uh, my talk is about capsular management in pediatric cataract. As you all know, pediatric eye is a growing eye, so 2-3 issues, especially in management of capsule, visual axis opacification, IOL power calculation. So I will be mainly dealing with how to deal with anterior capsule as well as posterior capsule, and what are the options that has been used in literature. So due to elasticity of capsule, there is a chances of peripheral extension, and due to low scalar rigidity, one should suture the port, main port as well as side port. It depends on age of the patient. Younger the age, one should suture the all the port. And due to vitreous upthrust, one should use high viscosity viscoelastic, and one has to go for deeper plane of anesthesia to contract the upthrust. And for instrumentation, a good quality retractor, coaxial forceps, coaxial seizure is required. Capsular staining is not required just for visualization. It has been found that elasticity of the capsule is decreased after staining. So one should stain the capsule even if there is immature type of cataract or clear areas. So coming to anterior capsulotomy, up to one age of 1 to 6 year, it has been found that one can go by forceps or retractor. It depends on personal choice, and again one should go for undersizing. Size of capsule, when you compare it by adult Capsulorrhexis, if you go for normal sizing, you will oversize. So always go for undersizing. So it depends on personal choice whether one can go for simple utrata or coaxial forceps, and always there should be centripetal force. At this stage, it was going outward, so I used coaxial to again pull inward to complete the rhexis. One technique, push and pull technique, has been described in literature. In this, two nick has been given on opposite side in the mid peripheral area, and one side is pushed and another side is pulled to make circular access. Posted stamp multiple capsulorrhexis has been described by Titial et al. In which 25 to 30 nick has been given to contract the peripheral pores. So basically to prevent chances of anterior capsular phimosis. Again, 4 incision capsulorrhexis. In this 1 to 2 millimeter size of 4 arcuate incision given in 4 quadrant, and inner part of the capsule is pulled to make a circular access. Femtosecond laser capsulorrhexis has also been described by use of table mounted femtosecond laser. Even Jepto has been used for making capsulorrhexis in pediatric cataract. It has been found in a long term study, it has been found that under age of 6 years, one can go for retractor, one can use retractor. It is more predictable compared to manual capsulorrhexis. In fibrosed capsule, it is very difficult to go initially pierce the capsule. So in that cases, one can use 260 to initially puncture, then one can decompress, and then one can use retractor. Sometimes retractor doesn't work, then you have to go for multiple nick by the coaxial seizure. and then one can enlarge the Capsulorrhexis. Coming to the posterior capsule management, again in posterior capsule management, as posterior capsule is almost 3 to 5 times thinner compared to anterior capsule, so it is very difficult to grasp. So don't go for overfill, and after initial nick, one should inject some viscoelastic to separate it from the anterior hyaloid face, and then one can use coaxial forceps. Again on the same principle, grasp and regrasp, and force should be always be centripetal. Just 1 minute. One can go for, after implanting the lens, one can go for posterior vitrectosis, that is more predictable, and less than 1 year of age, it has been found that it gives comparative result. So after vitrectomy, one can enlarge as per convenience, so that visual access should be clear. In one study, optic capture, one can go for posterior optic capture without vitrectomy. It has been found that chances of visual access or pacification is less when one can go for optic capture through posterior Capsulorrhexis. Bag in the lens implantation and lens in the bag implantation has also in lens in the bag implantation, basically both anterior and posterior Capsulorrhexis size is same, so that both anterior and posterior capsule margin it sticks, so it prevents migration of lens epithelial cells. Even pars placata posterior vitrectosis has been described by Basavda et al. In this, after implantation of IOL, first suture the main port, and then one can go for nicking the posterior capsule, and one can complete the posterior Capsulorrhexis. Again, it is more predictable compared to other technique. So to summarize, capsular management in pediatric cataract surgery determines the surgical strategy and site of IOL fixation. Deeper plane of general anesthesia is preferable to reduce vitreous upthrust. A stepwise understanding of capsular management results in good surgical outcome. Thank you very much.